เกี่ยวกับตัวไตนี่เป็นมาได้ปีที่เขาปี2นี่ครับ
ก็มากแล้วไปหากินบ่ได้ทำงานบ่ได้เนาะ
แต่ว่าก็แตกต่างหลายอยู่ครับนี่แหละแต่ก่อนนี่ไปขนาดไปรักษาโรคภายในใหญ่ปานนี้ค่าใช้จ่ายอย่างมหาศาลนะครับแต่ว่าไปโรคน้อยๆจังซี่ก็ได้ก็บ่ได้เสียตั้งแต่อันเปลี่ยนแปลงมานี่
ดีหลายๆหินแล้ว
ดีหลาย
HEFPA is a collaborative research project of a number of research teams from Asia and Europe. 6 countries in Asia and teams from those countries take part, as well as 4 universities in Europe or research institutes, and the World Bank is also a partner.
Bayar sendiri, mahal selalu itu. Waktu pertama itu waktu berapa ya? Satu kali berkali-kali itu. Terus yang kedua itu saya dua kali itu. Yang pertama itu satu nginap di rumah sakit itu 1 minggu. Yang kedua itu 10 hari. Ya utangnya sini aja. Saya tidak tahu nanti ya. Kita orang percaya ya. Kita ya sambil berdoa. Kita berdoa mohon pada Tuhan petunjuk biar gimana cara dapat biaya gitu.
The 2 types of subsidies that we tried are one is a premium subsidy, which offers a discount for premium payments. It's a 50% discount, bundled with information These are leaflets and also SMS reminders sent through mobile phones. And the other intervention is an added to the first subsidy, but this case it's designed to reduce the inconvenience of enrollment. Specifically, what we did is to assist them in completing the enrollment form and then in the submission of the enrollment form. Our main finding is that premium subsidies bundled with information can be effective. It can increase enrollment rate by nearly 5 percentage points. But the more effective intervention is the helping them enroll, reduce the the transactions cost or the the trouble of lining up and going to this PhilHealth office by themselves. These types of subsidies can work in the Philippines, can get them in, but only up to perhaps 50% of the target population. The remaining 50% are not going to be encouraged by a similar subsidy scheme if offered to them.
One of the problems that in particular Vietnam was confronted with was that there's a sort of missing middle, the group of informal workers that don't have coverage, not through because they don't have formal sector employment and they're not poor enough to receive the full subsidy. Now what we tried to assess in an experiment is the extent to which these people would be willing to buy voluntarily health insurance coverage if they receive a premium subsidy. The effect was only small. There was a slight increase in the uptake of those with premium subsidy, but that was not a significant effect and it remained fairly low, the coverage. Now on top of that, there was an additional experiment testing what additional uptake is achieved by giving people better information. So apart from the subsidy, they also received more information about what the benefits were of the health insurance. Again, we saw a slight increase in the uptake, but again, not of the sort that would be enough to reach high levels of coverage. So even with all the subsidy and the premium subsidy, the coverage rates remained fairly low.
ตอนเริ่มป่วยหนูปวดหัวจะปวดหัวมากเลยจ้ะปวดเลยทานอะไรลงไปก็จะอาเจียนออกมาจนปวดจนทนไม่ไหวจนเลยส่งโรงพยาบาลหมอก็บอกว่าติดเชื้อแต่ตอนนั้นก็รู้สึกเสียใจอยู่แล้วจ้ะแต่ก็ญาติพี่น้องคนในครอบครัวเขาให้กำลังใจดีก็เลยไม่มีปัญหาตอนไปนอนอยู่โรงพยาบาลน้ำหนัก51 โลไปนอนอยู่เดือนนึงเลย35 โลก็ดีขึ้นจ้ะสามารถทำงานได้ทำงานหนักๆได้ก็หมอให้ยามาทานก็รักษาแล้วก็เขาว่ายาอะไรดีก็ไปหามากินเดี๋ยวนี้เขารับได้หมดแล้วจ้ะเขาว่าฉันไม่ได้ติดเชื้อเขาว่าฉันไม่ได้เป็นแล้วเพราะว่าเขาเห็นว่าฉันอ้วนฉันทำงานได้อย่างนี้นะขนาดคนไม่ป่วยเขายังทำงานอย่างฉันไม่ได้เลย
Back in 2001, just after the Asian financial crisis, the new Prime Minister came in Thailand and wanted to bring universal health coverage to the entire population. And he announced that he was going to start the famous UC scheme, Universal Coverage Scheme, that was going to provide a universal entitlement to everyone in the informal sector.
So what we see in our study is that the Universal Coverage Scheme did improve the financial protection of households against medical expenditure risks. In fact, what we find is that out-of-pocket medical spending of households reduced by over 30% through the Universal Coverage Scheme. At the same time, households increased their use of healthcare. For ambulatory care, outpatient care, we find an 11% increase in use on average, and particularly large effects on the elderly and the poor that have specifically high healthcare needs. At the same time, inpatient care utilization, hospitalizations also increased rather dramatically by 20%. However, what we do not find is an increase in hospitalization, inpatient care use in rural areas, which is a point of concern since it indicates that there are still supply-side inequalities in the Thai healthcare system, at least on the regional level.
When you try to implement the policy on universal health coverage in a country, a strong health system is very important, especially at the district level. So you need to strengthen district healthcare system, particularly at the primary healthcare level, because this kind of health services are close to those who live in the rural and remote area of the country.
Now, the fact that Thailand was able to finance such a large-scale coverage extension certainly has to do with a growing economy. However, at the same time when Thailand introduced its universal coverage scheme, it also introduced a number of supply-side reforms to maintain cost control. Firstly, the universal coverage scheme puts heavy emphasis on primary care. The primary care providers function as gatekeepers that you have to see before you can be referred to higher-level secondary or tertiary care that is more costly. Secondly, the country introduced a single-payer system with a strong, independent single payer instead of an atomized system of insurance providers that have very little purchasing power. Thirdly, the Universal Coverage Scheme reimburses providers by a mixture of capitation and diagnosis-related group reimbursement that, unlike a fee-for-service system, does not incentivize providers to over-service patients for their own profits.
We would like to communicate with policymakers is that the comprehensive benefit package of health insurance is another key issue, because if you provide not comprehensive or just a small amount of a benefit package, sometimes it cannot cover and cannot improve equity in access to healthcare.
Karena gagal, yang pertama gagal untuk mabut, terus naik ke atas, terus diulang lagi. Ya, biayanya. Dan aja untuk kantong kan 250, setengah juta sendiri itu dari kalau nggak pakai Jamkesmas kan, jadi mahal.
Indonesia formulated its ambitions for universal health care in 2005, and the first steps that were taken was basically to cover the poorest. At that time it was called Askeskin, and then after about 2 years it was scaled up under the name of Jamkesmas. We thought that would be a good opportunity to see whether we could learn any lessons from this program and see what the effects were for those people that participated in this program. Now what we found is that actually there's quite some scope for intervention based on the lessons from this Askeskin program. The utilization of services increased quite strongly for the poorest. However, we do not find much effect of financial protections. In fact, for some households, especially in urban areas, we saw that out-of-pocket spending on healthcare actually increased a little bit.
But that increase was quite small compared to the increase in healthcare utilization.
Kemarin yang saya rasakan cuman Pak untuk ambil nafas itu agak sakit gitu. Itu hari Rabu. Nafasnya lama sebenarnya. Terus kemudian karena mungkin dari kader itu taraf ekonomi saya sudah dianggap udah membaik, kemungkinan ya itu ya cukup gitu, dianggap membaik, terus dialihkan atau saya diapes ke yang lain. Pesan sama adik saya sering nyarikan kartu.
So in addition to these national programs, what we also see in Indonesia in the last 10 years or so, especially in the last since 2005 or 2006, is a proliferation of local healthcare financing schemes. So these are schemes that are not provided by the national government, but by district governments. And we're interested to see whether decentralization and local policies can be effective in providing access to care and financial protection. There was no coordination with the central government, so what we see is that every district has a different type of feature in terms of benefit packages or who they're covering or which providers are contracted. And actually what we found is fairly disappointing. We found very little effects of these programs on access to healthcare. We found no effects of these programs on financial protection. We do see that there's a lot of variation between districts. Some districts outsource the management of their schemes to external insurers. And that seems to be quite an important feature for making these programs successful. Contracting both public and private providers appear to be quite important, and focusing on basic services seems to be very important.
Ini gara-gara riyen wonten lindu gedhe nika to. Hoyok-hoyok nang kula niki ajeng medal tibae kurugang. Kurugang omah niku. Asan kurugang omah ampun niki rusak. Nggih lejan nemen sanget nggih nganu. Bar lindu niku nonton penyakit pesta. Pesta niku jengkerut drijine telas. Anggere teng Puskesmas nek mboten kula omongi mboten digawani obat. Ming obat sing diinum niku to. Ning buntel kalih selep mboten. Nah niku wau kula sanjangi. Nek enten rodane loro nika nggih ra ketang brangkang saged. Niku rak ming nenggo kula. Niki anggere kowakanipun mantun kula nggih saged ngadeg mlampah ngangge teken.
The benefit package discussion and design has to be linked to the supply side. If you have a wonderful comprehensive benefit package, as they do in Indonesia now, but there is no supply side to really address the needs of the population, then I don't think the benefit package will be of have much impact in terms of really being able to provide the access, the quality, and the financial protection that people need.
In one study in China, we looked at the effect of the introduction of the rural health insurance program. Over the course of 6 to 8 years, China managed to go from a very, very low coverage rate to a very high coverage rate with the so-called NCMS program. The results were striking. We did find access to improve and utilization improved, mostly for inpatient but also for outpatient services. So people were responsive to this greater generosity. But surprisingly, financial protection did not improve. On the contrary, in some cases, people were confronted with higher expenditures. And that suggests that there is also a supply side response. So in response to the greater coverage of households, suppliers, providers, doctors, nurses, other healthcare providers may change their behavior and prescribe more expensively or prescribe more or better quality possibly drugs and in that sense increase the risk, the financial risk that households run by consuming services.
When you insure people, you might intend and think that services are going to be provided in a certain way to make coverage most effective, to make sure that it's equitable in that the poor are getting services supplied to them in the way that you hoped. If you don't actually incentivise that or structure that in a way on the supply side, you can do everything you want to on the demand side, but it's not going to work.
China has a major problem of overuse of drug, in particular antibiotics. And one, it is making healthcare very expensive, but more importantly, I'm sure you have heard that China has one of the highest drug resistance problem. So what I have done in HEFPA is to work with one provincial government to try to introduce a different kind of provider payment method at the primary care level in particular, which is proportional to the number of people in the catchment area that they serve. So the more people they serve, they get a bigger budget. It's prospective in the sense that if they can improve efficiency, save, that's their profit. But if they have cost overrun, that's their problem also. Now, this can lead to a problem that these healthcare centers might say, let me save lots of money and give people lousy care. So we also have to add another component, which is performance-based payment. In other words, out of the total budget, we withhold 30% of it at the beginning of the year, and the health center will be paid in the middle and the end of the year according to some performance, and all these performance indicators are related to quality and appropriateness of care. We were able to demonstrate that a capitation plus P4P was able to reduce that inappropriate drug prescription behavior in the form of reducing antibiotic use, reducing IV injection, which a lot of time is really not necessary. So one of the things we also learned is that maybe the government also needs to combine the supply side incentive with some other public education campaign to teach patients that don't ask for drugs if it is not necessary. It may do you harm.
One of the reforms that we investigated was the impact of paying district hospitals on a capitation basis, changing from fee-for-service. We were trying to look at what impact it would have on how the hospitals changed the way they provide services, what services they provide, how many they provide, the quality of services, and also if they had any changes in how they provide it to different groups of the population. So we found that with capitation payments that it pushed the hospitals to become more efficient in that they reduced the amount of services they provided to each patient. So they reduced the diagnostic imaging, the laboratory tests that they provided to patients, so they reduced their cost per patient. We also found that they didn't have an impact on increased negative health outcomes for patients. For example, you might think if they're reducing service provision, they may be under-providing. That could lead to side effects or complications or deaths of patients. We didn't find any impact on these outcomes. But we also found that between the patients that are insured and paid under capitation, that their service provision was reduced, while for patients still paying on a user fee basis, their service provision was increased.
Tam មណ្ឌលសុខភាពបានមណ្ឌលសុខភាពបញ្ជូនទៅតាមប្រព័ន្ធសេវាអង្គការកិច្ចការសាសនាបានផ្ដល់ព័ត៌មានខ្លះថាការបានមូលនិធិអង្គការដែលបានវិភាគទៅទៀតទៅដល់ខ្ញុំជាពីជនក្រីក្រវាមានតម្លៃពលភាពចំពោះរូបខ្ញុំម្នាក់ដែលខ្ញុំមានទរៈដូចជាជំងឺហ្នឹងវាការថ្នាំពេទ្យប្រើប្រាស់ក្នុងមណ្ឌលនៅមន្ទីរពេទ្យនេះអត់មានទេតែខាងមន្ទីរពេទ្យជួយទាំងអស់បាទហើយនៅក្នុងតេតេការអ្នកបម្រើក្នុងបានប្រព័ន្ធសេវាជួយពីដំណើរជាមួយពីនោះមកណាហើយពេលរយៈប្រហែលមើលបានពីសិនគឺទទួលបានប្រព័ន្ធសេវាតម្លៃ 32,000 នោះណាបាទក្នុងអ្នកបម្រើការមានប្រព័ន្ធសេវាបានក្នុងតម្លៃម្នាក់ 5,000 បាទកសាងកំណត់ជីវភាពទៅតាមកម្រិតវិជ្ជាចេះកាត់សក់ញ៉ាទីពីគាត់ណាបាទប្រកស្រាយវាគិតថាទៅក្នុងសភាពការតាក់ទងការលំបាកច្រើនណាស់បាទហើយដល់មានในខាងអង្គការពុទ្ធសាសនាបានជួយគ្រប់គ្រងហាក់បីដូចមានតម្លៃក្នុងជីវិតក្នុងសង្គមមួយខ្ញុំដែរបានមើល
The way in which the health equity funds operate is that they really tackle a central problem which many fee waiver schemes confront or experience. Usually, the provider of healthcare has a responsibility to decide whether a poor person will be asked to pay the fee or not. Now, if the provider decides to waive the fee, then the provider does not get paid, and so he has very little incentive to offer the fee waiver. What the health equity funds do is they remove that responsibility from the provider and give it to an NGO. The NGO decides whether the person is entitled to the fee waiver or not, and if it decides to waive the person should not pay the fee, then the NGO pays the provider. So the provider no longer has the perverse incentive not to award the fee waiver, and at the same time has an incentive now to provide care because they will be paid. We have found that generally they have a quite substantial impact on households' payments, out-of-pocket payments for healthcare. We find amongst the households that pay something for healthcare, on average their expenditures fall by around 35%.
Hai banនេះធ្វើឡើងដោយបុគ្គលិកអង្គការគាត់ចាក់ជូនទៅអ្នកស្ម័គ្រចិត្តភូមិដើម្បីចាក់ជូនអ្នកមានផ្ទៃពោះហើយខាងខ្ញុំចង់ឲ្យពិនិត្យម្ដងអញ្ចឹងប៉ុន្តែខាងគាត់គោលការណ៍របស់គាត់គឺចាប់ពី4ដងឡើងទៅបានគាត់ថេលុយឲ្យបានវាស្រួលត្រង់យើងមកដាក់ពណ៌ទៅស្រួលពេលយើងកើតអីអត់ខ្ញុំថានៅចិត្តទៅស្រួលជាងចឹងឲ្យគាត់មកពិនិត្យទៅខ្លះឲ្យបានច្រើនទៅវាល្អ
These vouchers are really in some ways quite similar to the health equity funds. The provider, the facility, has now a strong incentive to provide that care because if it produces the voucher, then the provider will get compensated by the NGO for the care that it's delivered. So we find that the operation of the scheme increases the probability that a woman will deliver in a public facility by 10 percentage points and has an even stronger impact on women who are poor.
Haiសម្រាប់ពេលសម្រាលគឺសម្រាលដល់លើសុខភាពឆ្មបមិនទៅសម្រាលនៅផ្ទះទេសម្រាប់លុយឧបត្ថម្ភ 60000 ក្នុងក្បាលកូនមួយហ្នឹង 2/3 សម្រាប់ខ្ញុំ 1/5 ហ្នឹងសម្រាប់បុគ្គលិកនៅធ្វើការជាមួយគ្នាក្នុងលើសុខភាពនេះ 1/5
The midwife incentive scheme appears to have been rather successful. And it seems that around the time that the scheme was introduced, the deliveries in health centres did increase rather substantially.
หลายอยู่แต่บ่มีผู้ไปหามาให้เนาะก็หาก็ไปหาหยังก็บ่ได้ เฮ็ดงานหนักก็บ่ได้ปานใดก็ไปรับจ้างรับหยังก็บ่ได้ยากน้ำเฮ็ดปอกเฮ็ดหยังนี่ก็บ่ได้ไปใส่ขามขึ้นก็บ่ได้ต้องกลับมาเฮ็ดมีแต่ซี่เที่ยยามพอสิไปหาหมอก็โทรเอาลูกค้ารถมาให้แน่สิไปหาหมอก็ว่ายามพอบ่มีเงินก็ไอ้พวกมาให้กินอันนี้บ้านได้แล้ว
We found that in Thailand, even though we have achieved universal health coverage since 2002, households still have the problem with financial consequence from health shock in terms of income loss. We are thinking about how we can provide more insurance in terms of disability insurance.
We have investigated the economic consequences of ill health for households in Indonesia, and we have our analysis has shown that for these households there is indeed an important economic risk through medical expenses, but especially for poor Indonesian households, especially in rural areas, we find that on top of these medical expenses there is an important income loss associated with ill health, and this income loss leads to a reduction in expenditures and consumption. Now these households, these Indonesian poor rural households, deal with this reduced income, reduced consumption by borrowing money from either informal or formal money lenders, and by cutting back on other expenses, and by using their savings, which of course has important long-term negative consequences on their welfare.